Yeah, so good morning, everybody, and thank you, Dr. Unni, for the opportunity to present this. My job has been made really, simple by the previous presentations because everybody has, I think, really uh, with excellent illustrations illustrated the pathologies. So I think our viewers should not have any problem in understanding or rather even recognizing it in their own clinical practice. So mine is basically a picture-based talk. I'll be showing pictures and just recapitulating the salient features of most of the entities already presented. So I'll give everybody about 5 to 10 seconds before I move on. What could this be? So this is a case of dry AMD, and if you look at the RPE and these conical projections, so basically this is reticular pseudodrusen, as I think Dr. Manoj had, as Dr. Unni had said. These are hyperreflective material accumulations. This is between the RPE and the ellipsoid zone. And initially it causes bowing or the distortion of the ellipsoid zone, but then it causes destruction of the ellipsoid zone. The later stages have conical masses and the disrupted external retinal structures. This is a marker for increased risk of GA and wet AMD. And if you have this in your, when you're beginning your treatment, it is a marker of post-treatment atrophy. And it is very frequently associated with type 3 CNVM. The next slide. This is something that Dr. Unni had talked about in the first talk. So if you look at this region here, this is an area of complete RP and outer retinal atrophy. This is basically showing choroidal hypertransmission and absence of RP band measuring more than 250 microns. And there is overlying photoreceptor loss and outer retinal thinning. When this is incomplete, it is called incomplete RP and outer retinal atrophy, where the RP is discontinuous, but some at least evidence of RP is present. There is also photoreceptor loss and INL OPL dipping or subsidence into the defect. So these are two examples here. If you see the triangle in the first one and in the second image, what could this be? This is a subset of incomplete IRORA, that is incomplete RP and outer retinal atrophy. This is nascent GA, where the RP is discontinuous but present. There is photoreceptor loss, the INL OPL dip, and there is a wedge-shaped or triangular hyporeflectivity seen dipping towards the RP. This is a very strong marker for future geographic atrophy. Now, I think this is one of the most remarkable or rather, easy to recognize features if you see it on your OCT. If I can mark at least these two features, if you can see my marker here and here. These are basically outer retinal tubulations. They are round or oval structures in the outer retina with hyper-reflective borders and variable intraregional reflectance. Now, what somebody may call it as an intraretinal fluid, but though it resembles CME, what is different between CME and ORT is the presence of hyper-reflective borders. This is not present in the routine CME fluid or intraretinal cysts. These are usually stable over time, and they have no response to anti-VEGF. It's important to recognize them so that you don't keep on injecting in the hope of drying these. They are a sign of chronicity and atrophy, and they are usually related with pretty poor vision. Okay. This is what Dr. Darius had referred to in his talk. If you can see, there is an outer retinal hyperreflective band. So this is basically a subretinal hyperreflective material, or SHRM, SHRM. This is a morphological feature. This has no direct pathological correlation. It's a hyperreflective material located external to the retina and internal to the RP. This can represent CNVM, hemorrhage, fibrous tissue, etc. And mostly it is present in treatment-naive AMD. When you start treatment, the membrane shrinks, the blood goes away. So the incidence of SHRM also reduces. You see less of SHRM. If you have a very large area of SHRM or very thick SHRM, it's usually a poor prognostic sign. So this is an interesting entity which Dr. Unni had pointed to. This is what is called a choroidal cavern. So if you see, there was a large area of hyporeflectivity in the choroid. It's an infrequent peculiar finding, mostly seen in atrophic AMD, but can be present with wet AMD also. It's a gaping angular hyperreflective cavity in the area that is devoid of choroidal vessels, and it's often seen with punctate or linear hyperreflectivities internally. Choroidal caverns may possibly arise from non-peripheral ghost vessels or persistence of stromal pillars. This is a octa finding. So what you can see that there is a membrane or a abnormal neovascularization, but it does not have any exudation on the structural OCT. So this is what we call as a quiescent CNVM or a non-exudative choroidal neovascular membrane. Clinically and structurally, it presents as no activity on a structural OCT. But if you investigate with the octa, 7 to 14% of intermediate AMD may have such an underlying membrane. It is its role is thought to be protective for the RPE, and what they have noticed is if you treat these patients with anti-VEGFs, or if there is a IMD without this kind of a lesion, geographic atrophy is faster in those cases. Geographic atrophy is slower in cases where you have this kind of a quiescent CNVM underlying the RPE. 20 to 26 of this may convert to exudative CNVM in 5 years' time, so a close watch is warranted. No active intervention is warranted when there is no leakage on the structural OCT. Now, this is a finding again that we see in several of our AMD patients, especially the ones that have been taking chronic treatment for us. If you look at the characteristics of the PED, this is what we call as a multilayered PED. It is basically a chronic fibrovascular PED with fusiform shape. It has a fusiform shape. It is basically, it has layers of fibrous tissue. These are visible as organized layers, hyperreflective bands. In between the bands, there is hyporeflectivity. So in conjunction with CNV, this is always present in conjunction with CNV that is adherent to the RPE undersurface. And it is mostly seen in long-term, in CNVMs which have a FVPED to begin with and have been on anti-VEGF treatment. So the CNV process is limited to under the RPE with no kind of, the retina overlying it being protected. And usually they are associated with good visual acuity. When there is contraction of these fibrous bands, there may be a prechoroidal cleft that is formed. That is a clear area between the choroid and these fibrous layers. This is one of the most, characteristic and a very stark observation if you ever come across a patient with this kind of a OCT. This is what we call as a focal choroidal excavation. Areas of choroidal pitting, they are observed near the macula. Sometimes they can be a little away from the macula also. But you call it a focal choroidal excavation only when it is not associated with scleral ectasia, posterior scapholoma, or a scleral scar. So if you have any of those, then you don't call it a FCE. This can cause symptoms like decreased vision and metamorphopsia because of the mechanical bending of the retina and the photoreceptors. And though its etiology is not fully understood, luckily for us, the prognosis in most of these cases is quite good. However, in some cases, it may be accompanied by a choroidal vascular disorder like PCV, CNV, or sometimes even CSR. Now, Dr. Manoj had talked to us about epiretinal proliferation and epiretinal membranes. So, if you any guesses to this? So, this is a scan going through the fovea in a patient with a chronic ERM, and you cannot make out the Henle's layer and the hypervelocity going to the top of the fovea. What you see instead are band-like structures even over the fovea. So this is what is called as ectopic inner foveal layer. This refers to the OCT appearance of banded tissue resembling, abnormal retinal layers over the foveal region in cases with chronic epiretinal membranes. Usually, again, almost never seen in membranes of a shorter duration. Mostly it resolves with surgery, and this is basically the late stage of ERM with a lot of distortion of the retina. So it is associated with a poor visual prognosis after surgery. If you have a ERM without EIFL, the surgical prognosis is usually better. Now, if you look at the outer retina here, what do you see? There is fuzziness of the ellipsoid zone and the elongated photoreceptor. This is what is referred to as the ulta of ABC, that is CBA, central bokeh abnormalities. It refers to the distortion of the foveal external retinal complex, including photoreceptors, EZ and the ELM. Elongation fuzziness is usually because of the mechanical stretch from the ERM, the traction because of the ERM, or sometimes in retromacular traction. There is sometimes, very occasionally, there is neurosensory detachment also, a very small limited one, and it usually presents in earlier stages of ERM. Usually it has a very good prognosis of surgery. You get very good visual recovery if you, even if you have this preoperatively. Now again, this is an exciting entity. It has become very popular nowadays. If you have a patient who complains of a paracentral scotoma, and otherwise clinically you may not see anything, you may see something on the infrared image, but not very clearly on the fundus image. And OCT shows you a hyperreflectivity of the middle layer. So this is basically paracentral acute middle maculopathy. It shows up as hyperreflective parafoveal bands, but is limited to the inner plexiform layer to outer plexiform layer. Usually it does not extend deeper to the outer plexiform layer. The causative factors are ischemia at the intermediate and the deep capillary plexus levels. And the associations are with some vasculitis and with certain vascular retinal diseases. Usually it resolves with thinning of the affected layers and a scotoma. This has to be distinguished to what this entity is, a similar kind of a hyperreflective band, but present a little deeper in the retina. This is called acute macular neuroretinopathy, and the earliest lesion is usually hyperreflective band at the level of the outer plexiform layer, outer nuclear layer, and then with time it kind of migrates downwards towards the RP, and you when it resolves, it leaves a hyperreflectivity near the in the infrared reflectance, which is best seen, and usually it leaves a scotoma on resolution. Coming to what was talked about the vascularity of the structures by Dr. Anand Rajendran. This is what is a classic case of drill, where you have the inner retinal layers disorganized. You cannot find the boundaries between ganglion cell, IPL complex, INL or OPL cannot be identified separately. Very early on, it can be reversed, but later on, it is if it is extensive, it is usually associated with vision loss and a poor prognosis. It is a biomarker associated and predictive of ischemia in DME. This is something that is ubiquitous in several diseases of the retina where you have leakage, and it has to be distinguished from hard exudate. These are hyperreflective foci. If you see, usually hyperreflective foci or dots, as they are sometimes referred to, or sometimes even called spots. HRS, HRF, and HRD are the same thing. They are associated with vascular causes of macular edema, usually in the range of 20 to 40 microns, not more than that. And they have no to very minimal shadowing. They are markers of active disease. And with whatever treatment you institute, anti-VEGF for AMD, or say a steroid or anti-VEGF for DME, they disappear on with treatment. Their number may be correlated to the preferential response. So if you see a lot of them, you may want to give steroids because they are thought to be activated glyocytes, which basically are a marker of inflammation. Now, before I end the last 2 minutes, this is not related to either of the talks. This is a case which actually I discussed with Dr. Darashov yesterday, and he said in an imaging session, this is good to put. This is a gentleman who came to us day before yesterday actually, with a complaint of sudden loss of vision. He had a recorded vision 1 month back of 6/9 with a little bit of cataract. And then 5 days back, he read the newspaper, kept it, and then picked up a novel. And he said, I can't, I was finding it difficult to read, which progressed over a few hours. And this is what the color fundus looked like. The gentleman is not a diabetic, he's only a hypertensive. And the autofluorescence doesn't show anything remarkable. The FFA early phase is quite unremarkable. In the late phase, you see outer retinal staining along the inferior arcade. If you look at the color photo, it almost looks like a CSR. But when you look at the late phase FFA, you see a deep outer staining along the inferior arcade, a little bit of disc staining as well. What do you find on the OCT? If you look at the OCT, you have this hyper-reflective outer retinal band limited to the outer retina alone along the arcade. So these are a series of scans that I've taken along the arcade. You see here some disruption of the external limiting membrane, the EZ and the photoreceptors along all the area that had shown staining. So now I'll open the case for discussion. Any guesses, Dr. Manoj, Dr. George? If Dr.
Is it Azure?
So yes, that was one of the things that that we are considering, Azure. Yes, but then again, the kind of the location of the lesion, the picture on the fundus.
The autofluorescence.
Pardon?
The autofluorescence also is not
Yeah,
very
autofluorescence
sensitive.
also is not suggestive of azure. The autofluorescence is nearly normal.
The outer retinal involvement and a fussiness in the outer retina looks inflammatory, and
Correct.
and the disc staining and radiating from the in and around the disc to the periphery. I mean, my best would be azure. Probably you could put on the diagnosis.
Maybe I think the autofluorescence may show a little time to show the changes. I am not very sure of that. Whether there is a delay in the presentation of azure, but then I thought this is a nice case. Any last comments, Dr. Oni?